Welcome back, everybody. Ready for another deep dive?
Absolutely. Always ready to go deep.
Well, today we're diving into a world where every breath and decimal point matters.
Oh, yeah.
Critical care,
Love it.
specifically acid-base balances
Okay.
and the power of mechanical ventilation.
Two sides of the same coin, really. You can't have one without the other in the ICU.
And, I've always been intimidated by ABGs in those ventilator settings. They
Yeah.
just seem so,
Cryptic.
yeah, cryptic and high stakes.
For sure.
But I'm hoping that by the end of this deep dive, I'll be able to look at them not as these scary puzzles, but clues to guide us towards better patient care.
I like that. It's like a secret decoder ring, right?
Yeah.
Unlocking the secrets of the body.
Okay, let's start with the foundation.
Mm-hmm.
We all learned about pH back in high school chemistry,
Right.
but in the ICU, it's a whole different ballgame.
Totally.
So remind me, why is pH such a big deal in critical care?
You're right. It's not just about remembering that 7 is neutral. Even slight shifts can make a huge difference in a patient's stability.
Right.
Like, let's say a patient has sepsis. They might have a slightly acidic pH,
Okay.
which can then impact their heart function, their blood pressure, even make them more prone to arrhythmias.
So it's not just about numbers on a chart, it's about how those numbers reflect the body's balance.
Exactly. That's why we need to be able to quickly identify and interpret those acid-base imbalances.
Like detectives, looking for those clues to understand what's happening.
I like it. Detective work for sure.
So what are our main tools to investigate these imbalances in the ICU?
One of the most powerful is arterial blood gas analysis, ABGs for short. They give us a real-time snapshot of the patient's pH, CO2, and bicarbonate levels.
Okay, so those are our three key players: pH, PaSO2, and HCO3.
You got it.
How do they all fit together?
Think of it like a seesaw, okay?
Okay.
PaSO2 is on one side, that's the acidic component, and then you have HCO3 on the other, the basic component.
Okay.
And right in the middle, keeping it all balanced, is our pH.
So if the PaSO2 side goes up, meaning more acidic,
Right.
the HCO3 side needs to go up to compensate and maintain that balance.
Exactly. The body is always working hard to keep that seesaw level.
Wow. But what happens when the body can't keep up? When that seesaw tips too far?
That's when we see the 4 primary acid-base imbalances: respiratory acidosis, respiratory alkalosis,
Right.
metabolic acidosis, and metabolic alkalosis. Each tells a different story.
Okay, let's break it down, starting with respiratory acidosis. What's going on there?
So in respiratory acidosis, the lungs aren't effectively removing CO2.
Okay.
Our acidic component, remember, this could be for lots of reasons: COPD, pneumonia,
Mhm.
or even an opioid overdose that suppresses breathing.
So CO2 builds up, that acidic side gets heavier, and pH drops.
Right, and as the pH drops, things can get bad quickly. The
Mhm.
heart has to work harder, blood vessels constrict, the brain can get foggy.
Wow, so even a small shift in pH has a huge impact. Now, what about respiratory alkalosis? Is that the opposite? Losing too much CO2?
You got it. The lungs are getting rid of CO2 too fast,
Okay.
making the pH go up.
And what usually causes that?
Anything that causes someone to hyperventilate. Anxiety, pain, fever, even some medications that stimulate breathing can do it.
So in both respiratory acidosis and alkalosis, the lungs are the main drivers of the imbalance.
Yeah.
But what about the metabolic side? When do the kidneys come into play?
Good question. That's where metabolic acidosis and metabolic alkalosis come in.
Okay, so in those cases, the problem isn't with the lungs, but how the body handles acids and bases.
Exactly. And the kidneys are vital here, regulating those bicarbonate levels.
So in metabolic acidosis, there's either a loss of bicarbonate or a buildup of acids causing the pH to drop.
Right. Like in our seesaw analogy, something's either taking weight off the HCO3 side or adding it to the CO2 side, throwing off that balance.
And what are some examples of that?
Oh, there are a bunch. Diabetic ketoacidosis is a classic one. The body breaks down fats for fuel, creating ketones.
Which are acidic. Severe diarrhea is another because you're losing bicarbonate through your stool. Kidney failure, shock, even some poisons can do it.
So lots of potential culprits there.
For sure.
What about metabolic alkalosis? What causes that?
It's a little less common, but still important. It happens when the body gains too much bicarb or loses too much acid, making the pH go above 7.45.
So adding weight to the HCO3 side or taking it off the CO2 side of our seesaw?
Precisely. And this can happen for a few reasons. Vomiting. For one, you lose stomach acid.
Right.
Some diuretics can contribute by causing low potassium, which indirectly increases bicarb levels.
Okay.
Even overusing antacids can sometimes lead to it.
Wow, this whole acid-base balance is so complex. But our bodies are amazing, right? They don't just give up when these imbalances happen.
Oh, absolutely. The body has these incredible backup systems, these compensatory mechanisms to try and get that pH back in check.
So let's talk about those. What happens behind the scenes when the body tries to fight back?
Well, remember our three musketeers of pH regulation: chemical buffers, the respiratory system, and the renal system.
You got it. They all work together to counteract the imbalance. The buffers act first, like a quick fix, to minimize the initial pH change.
Right.
Then the respiratory and renal systems kick in for the long haul.
So if the problem's respiratory, the kidneys try to compensate, and if it's metabolic, the lungs step up.
Exactly. Teamwork makes the dream work, right?
Right.
For example, in respiratory acidosis, those kidneys will hold on to more bicarbonate to fight the excess acid. And in metabolic acidosis, the lungs work to blow off more CO2, getting rid of that acidity in the blood.
Fascinating how the body's always making these adjustments,
Yeah.
trying to keep that pH seesaw balanced.
Yeah.
But how can we see this happening? How do we know if the body's winning the fight?
That's where ABG interpretation comes in.
Okay.
By analyzing the pH, PSO2, and HCO3, we can see the type of imbalance and how well the body is compensating.
Okay, I'm starting to feel like an acid-based detective.
That's the spirit.
But I think I need to practice my skills. Do you have any real-life ABG examples from your research that we can look at together?
I do. Got a few cases that'll really test your detective work.
Awesome. Let's see if I can crack the code.
Let's do it.
I think I'm starting to get the hang of ABGs.
Yeah.
It's like learning a new language, the
Yeah.
language of the body's balance.
The body's internal systems.
Exactly. It's like each ADG is a snapshot
Mhm.
of a dynamic process.
A constant battle between opposing forces.
Exactly.
Speaking of battles, let's talk about another crucial aspect of critical care.
Okay.
Mechanical ventilation. A tool that can literally breathe for patients
Right.
when their own lungs are failing them.
It's amazing that we have the technology to take over such a vital function.
Right.
But I have to admit,
Yeah.
I get a little overwhelmed when I see all those tubes and settings.
Yeah, I get that.
Mm.
It can be a bit daunting at first glance, but the key is to break it down.
Okay.
Understand the why behind each piece.
Okay, so let's start with the basics.
Yeah.
How do we connect the patient to a ventilator?
Well, there are two main ways. Through an endotracheal tube,
Okay.
or an ET tube for short, or a tracheostomy tube.
So the ET tube, that's the one that goes through the mouth and down into the trachea.
Right, exactly.
Now-
That's the one you see in the movies when someone needs to be intubated.
Right.
It's the most common way to give short-term ventilation.
Okay.
And since it goes through the vocal cords, patients can't speak while it's in place,
Right.
which can be really frustrating for them, of course.
Not bad, yeah.
And the tracheostomy tube, that one goes directly into the trachea through an opening in the neck,
Mhm.
usually used for longer-term ventilation or when the airway is blocked higher up.
Okay.
And with either type of tube, you need to be really careful,
Okay.
making sure it stays in place, the airway is clear, and the cuff is properly inflated.
So there's a lot of monitoring and specialized care involved.
Absolutely. You're like the patient's voice because they can't really communicate their needs in the usual way.
Okay, so we have our patient connected, whether it's an ET tube or a track tube. What happens next? How do we actually control the ventilator?
That's where the ventilator settings come in. Think of it as the control panel for the patient's breathing.
Ooh, the control panel.
Yeah. We can adjust a bunch of different parameters to tailor the ventilation to their specific needs.
Okay, give me the rundown of the control panel. What are the key settings we need to understand?
One of the most important is tidal volume, or VT. It's basically how much air is delivered with each breath.
So a bigger VT means a bigger breath.
Yeah, you got it. And we adjust it based on the patient's size and their lung condition. Don't want to overinflate those lungs.
Makes sense, yeah. What else is crucial?
Respiratory rate is another big one. That's breaths per minute,
Okay,
setting the pace of their breathing.
so we're controlling the volume and the speed of the breath.
Exactly. Then we've got FiO2, which stands for the fraction of inspired oxygen.
So if they need more oxygen, we can increase the FiO2.
Exactly. We fine-tune it to keep their oxygen saturation at a safe level.
Okay,
But too much oxygen can be just as bad as too little, remember that.
right. That makes sense. Every intervention has risks and benefits.
Absolutely. Now, there's also PEEP, which stands for positive end expiratory pressure. PEEP.
That one always sounds a little mysterious to me.
Yeah, it can be a bit counterintuitive at first. Basically, it helps keep the tiny air sacs in the lungs.
The alveoli.
Yes, from collapsing at the end of each breath.
So it's like back pressure that keeps the lungs from deflating too much.
Exactly. Super important for patients with things like ARDS, where those alveoli can collapse really easily.
Okay, that's making more sense now. Any other settings I should be aware of?
Yeah, there are a few others. Sensitivity, for example, determines how much effort the patient needs to make to trigger a breath from the ventilator.
So it's like finding that sweet spot between the machine doing the work and the patient being involved.
Right, we want them to work together as much as possible. And then there's the IE ratio, which controls how long the inhale lasts compared to the exhale.
Okay.
That gets adjusted based on the patient's lung characteristics.
Wow. So many settings to juggle. It's like conducting an orchestra.
Ha ha, that's a good way to put it, making sure all the instruments are in harmony.
Yeah. But it's not just about the settings, right? There are different modes of ventilation, too.
You got it. We've got a whole range of ventilator modes,
Yeah.
each with their own quirks and indications.
Can you give me a quick overview of the main modes we might see in the ICU?
Sure. One way to categorize them is by whether they're volume controlled
Okay.
or pressure controlled. In volume controlled modes, the vent delivers a set volume of air with each breath,
Okay.
no matter the pressure.
So it's like saying, this is how much air you're getting no matter what.
Haha, pretty much.
Yeah.
One of the most common volume controlled modes is called assist control, or AC.
Okay.
The vent delivers a certain number of breaths per minute at a set tidal volume. If the patient tries to breathe on their own, the vent helps them out by delivering the full tidal volume.
So it's like a safety net, making sure they're getting enough air, even if they're weak.
Exactly. Then there's SIMV, synchronized intermittent mandatory ventilation,
Okay.
which is similar to AC, but it lets the patient take some breaths on their own between the vent breaths.
So they have a little more control.
Right, exactly. It's often used as a step towards weaning them off the vent.
Okay. Makes sense. What about those pressure-controlled modes? How are they different?
So in those modes, the vent delivers breaths at a set pressure,
Okay.
and the volume of air changes based on the patient's lung compliance.
So instead of a specific volume, we're setting a target pressure.
Exactly. One example is pressure support ventilation, or PSV. It gives a boost of pressure when they inhale, making it easier for them to take a breath.
So it's like giving their breathing muscles a little help.
Right. Often used to help them transition off the vent.
Okay, I'm seeing the logic behind the different modes.
Yeah.
Like different tools for different jobs.
Yeah, exactly. And which mode we use depends on a lot of things. Their condition, how well their lungs are working, their overall stability.
This is fascinating. But how do you keep track of all the different settings and modes?
Honestly, it's a lot to juggle, but it gets easier with experience.
Okay,
You start to develop a feel for what works best in different situations.
so it's knowledge, experience, and a little bit of intuition.
Exactly. And don't forget constant vigilance.
Right.
You have to be always monitoring how the patient is responding,
Yeah.
looking for clues that you might need to change the settings or try a different mode.
Speaking of vigilance, what about all those alarms that go off?
Oh, yeah.
In the ICU, I always get a little nervous when I hear them.
I understand. Alarms can be alarming, but they're actually there to help us. They're how the ventilator communicates,
Okay.
letting us know if something might be wrong.
So it's like the ventilator's language.
Exactly. And it's our job to learn that language.
Okay, I'm ready to become fluent. What are some of the most common alarms we should know?
Well, one of the most frequent is the high pressure alarm.
Okay.
That usually means something's making it harder for the vent to deliver the breath.
So it's like the ventilator is hitting resistance.
Yeah, exactly. Could be a lot of things. Maybe the patient's biting on the ET tube, secretions are building up.
All right.
Or it could be something more serious, like a bronchospasm or even a pneumothorax.
So you have to think fast and figure out what's going on.
Exactly. Another common one is the low pressure alarm, which usually means there's a leak somewhere.
Like a disconnected tube or a hole in the circuit?
Yep, you got it. We got to find that leak. And then there are alarms that are more about the patient's breathing, like the apnea alarm.
Right.
If they stop breathing for a certain amount of time.
Oh, wow.
Or the high and low tidal volume alarms, if the volume's too high or too low.
Sounds like there's an alarm for everything.
There are quite a few, yeah, but they're all there for a reason. They're designed to keep the patient safe and let us know about problems early on.
I'm definitely feeling a lot more comfortable with alarms now.
Good.
But what happens when the patient starts to get better? How do we get them off the ventilator and breathing on their own again?
That's the goal. That process is called weaning, like teaching a baby bird to fly.
I like
Slowly but surely until they can soar on their own.
How do you know when they're ready to start weaning?
Well, we look at a few things. The reason they needed the vent in the first place needs to be gone, or at least much better.
Yeah.
Their lungs have to be clear, and they need to show signs of being able to breathe on their own.
So we're looking for signs of strength and recovery.
Exactly. And we can test their readiness with something called a spontaneous breathing trial, or SBT. We disconnect the vent for a bit,
Okay.
see how they do.
So it's like a test run.
Exactly.
Mhm.
If they do well, we can start gradually decreasing the support from the ventilator until they're breathing completely on their own.
That's incredible. But I know there can be complications with mechanical ventilation too.
Of course there can be. One of the biggest concerns is ventilator-associated pneumonia, or VAP.
Right, I've heard of that. That's pneumonia that develops after being on a ventilator, right?
Yes, 48 hours or more after intubation and ventilation, to be specific.
Okay.
It's a big problem, unfortunately affects a lot of patients.
Why is it so common in ventilated patients?
Well, think about it. Intubation itself disrupts the normal defenses of the airway, making it easier for bacteria to get in. And the ventilator tubing, if it's not perfectly clean, can become a breeding ground for germs.
So it's a few things working together that increase the risk of infection.
Right, exactly. But the good news is we have ways to prevent VAP, like good hand hygiene,
Right.
keeping the head of the bed elevated,
Okay.
good oral care, and careful management of the vent settings.
So it's about minimizing those risk factors.
Absolutely. And being on the lookout for signs of VAP, like fever, changes in their sputum, or a new infiltrate on a chest x-ray.
So constant monitoring is key. Managing a patient on a ventilator sounds like a delicate dance.
It really is. Always adjusting, responding to their needs.
It sounds incredibly challenging and rewarding. I have a lot of respect for what you do.
Thank you. It is both challenging and rewarding, for sure. I think we've covered a lot today. Hope you're feeling a little more comfortable with this world now.
Definitely am. It's not just about memorizing facts, it's about understanding the systems, the balance,
Right.
and how we can support patients in these critical moments.
Beautifully said. And it's about seeing them as a whole person, not just data points. They each have their own story and their own incredible strength.
Wow, we've really gone deep on this one. Explored the balance of acid-base, decoded those ABGs, and even tackled mechanical ventilation.
Yeah, it's been a whirlwind tour of critical care. Every decision, every little tweak we make has such an impact on the patient.
It's like we're always walking that tightrope,
Mm-hmm.
trying to support them without doing any harm.
That's a great way to put it. That's why it's so crucial to really understand these concepts.
Right.
They're not just abstract ideas, they're the foundation of how we think in critical care.
So let's recap some key takeaways from our dive.
Okay, sounds good.
What really stuck out to you?
Well, I think that pH balance being more than just a number is huge.
Right.
It's all about the body's ability to maintain that balance, that homeostasis.
Yeah.
And even tiny changes from that 7.4 can have big consequences.
Exactly. We talked about how a slightly acidic pH can affect the heart, blood pressure, even increase the risk of arrhythmias.
Right, it can throw off so many systems. And remember, the body uses those three main systems.
The buffers, the respiratory system, and the renal system.
Exactly, to try and keep everything in check, keep that pH seesaw balanced.
And when they can't keep up, that's when we see those four main acid-base imbalances.
Respiratory acidosis, respiratory alkalosis,
Right.
metabolic acidosis, and metabolic alkalosis. Each one tells us something different is going on.
And we use ABGs to decode those messages, figure out the type of imbalance and how well the body is compensating.
Right, those ABGs are like our secret decoder rings.
I was so intimidated by them at first, all those numbers and abbreviations.
I know, they can be overwhelming at first.
But now I see them more as a window into what's happening inside the patient.
That's the shift in thinking. And then, of course, we explored mechanical ventilation, such an amazing tool in critical care.
I know, it's incredible that we can breathe for patients when they can't do it themselves.
Yeah.
But all those settings and modes,
It's a lot.
it really is.
But the more you understand why we do what we do,
Mhm.
the easier it gets. Why we adjust the tidal volume, set a certain PEEP, choose one mode over another.
It's not about memorizing, it's about understanding the principles
Yeah.
and how they apply to each patient.
Exactly. And being really observant, watching how the patient responds,
Right.
and being ready to adjust if things aren't working.
And we can't forget about those alarms. I'm not nearly as scared of them now that I understand what they mean.
Good. Those alarms are our friends, even if they're loud sometimes.
This has been such an incredible journey learning about all these critical care concepts.
I'm glad you enjoyed the deep dive.
I feel so much more prepared to think critically about these situations.
That's what it's all about. It's not just about the facts and figures, it's about the whole picture.
Right, how all the systems work together, that delicate balance,
Hmm.
and how we can support patients in those critical moments.
Well said. But before we wrap up, I want to leave our listeners with something to think about.
Okay, what's that?
We've talked a lot about the technical side of critical care, the settings and interventions. But what about the human side?
Okay.
How do we balance that technical expertise with compassion,
Right.
advocate for our patients,
Mm-hmm.
while also recognizing the limitations of what we can do?
That's a powerful question. Critical care isn't just about machines and numbers.
No, definitely not.
It's about people. It's about their dignity, their comfort, and their strength in the face of all of this.
Absolutely. It's been great diving deep with you today.
You too. And to everyone listening, thank you for joining us. We hope you learned something new, and we'll see you on our next deep dive.